Good morning to all. So I will be speaking on HVPG and TJLB in ACLF group of patients. So my talk will outline in history of TJLB, indications and contraindications, how to perform HVPG, TJLB, IL-based data and future research. So HVPG TJLB is important because ACLF progresses rapidly, so decisions are time critical. And apart from measuring portal pressures and biopsy, it is important to do both safely to change outcomes. Higher HVPG in ACLF patients tracks early varicose risk, refractory ascites, AKI, and short-term mortality. If we go back to history, then this is Charles T. Dotter. In 1964, he has done first time TJLB, but it was in dog. And in 1967, it was in UCLA that first human transjugular liver biopsy was done through a 18 gauge modified Roche needle, which is being still used. Roche apparatus is still available with us for performing the TJLB. So, and after that, 61 patients data was published in NEJM. In that, they showed that both biopsy and cholangiography were done in 36 patients, and it is important that you can see that 89% biopsy specimen was achieved successfully. So at that time also 89% TJLB was successful. So indications are liver diseases with contraindication to percutaneous biopsy, which is whether INR is whether it based on institutions. So INR more than 1.5 or platelet less than 50,000, we do not perform percutaneous biopsy. Requiring simultaneous hemodynamic assessment, presence of ascites, they are the contraindications of percutaneous biopsy, so we perform TJLB. As such, there is no contraindication for TJLB, but relative contraindications include lack of suitable venous access, internal jugular vein, and biopsy of a focal lesion, which is not, because it is a 2D image fluoroscopy, so we will not be able to find the focal lesion through the transjugular 2D images. So ACLF couples systemic inflammation and rapidly escalating portal pressure. Mortality is very high in 28 to 90 days. And at bedside, apart from MELD, CLIF, ARC score, the portal hypertension reducing strategy are still lacking. Combining hepatic and systemic hemodynamics as a driver of ACLF can help in prognostication. So if we look at that study, which is hepatic and systemic hemodynamic derangement predict early mortality and recovery in patients with acute and chronic liver failure, it was done in ILBS. 57 patients were enrolled, although 46 patients died, but the baseline HVPG in the patient who survived reduced, and the reduction in HVPG correlated clinically with the CTP score, MELD score, and also the systemic hemodynamic score like cardiac index, pulmonary vascular resistive index, SVS systemic vascular resistive index. So the improvement clinically also improves the systemic hemodynamics, also the pulmonary hemodynamics. And if you look further, they concluded that the high HVPG and hepatic encephalopathy were found to be independent baseline predictor of mortality in these ACLF group of patients. And on the left side, it is the systemic vascular resistive index, which improved after the 3 months in the patient who survived. Also, the histology in ACLF, it is important. In this study, they have done core needle biopsies from ACLF patients as per the EASL, and they found that hepatic necrosis, dense lobular inflammation, cholestasis, ductular reaction, hepatocyte degeneration, advanced fibrosis. But the dense lobular inflammation was predictive of mortality. So biopsy and pulmonary hemodynamics, hepatic hemodynamics, systemic hemodynamics are important in ACLF to prognostications. So higher HVPG as predicts the early varicose risk, refractory ascites, AKI, short-term mortality, also ICU. It refines the ICU intensity and surveillance candidates. And the threshold is more than 10 millimeter of mercury is significant, 16 is high risk, and 20 is very high risk for mortality in ACLF group of patients. If you see, this is a very important slide that while we measure the HVPG in these patients of cirrhosis and ACLF and NCPF, this is a normal cirrhosis and ACLF patients. We are measuring the hepatic wedge pressure, and which is almost contributing to the portal pressure gradient. You can see this is a cross, so there is no intersinusoidal connections. So the wedge hepatic pressure correlate clinically with the portal pressure. But in case of NCPF, non-cirrhotic portal hypertension or pre-sinusoidal, You can see these are the collaterals, intersinusoidal collaterals. So the pressure which is measured by the hepatic vein, wedge hepatic pressure, would be low or normal. So, but it will it will not corroborate clinically. So we need to measure directly portal pressure here for these patients to better identify the patients who have high portal pressure and they have high chance of developing collaterals and gastric varices. So if you see the image like this while doing the cholangiography or hepatography, then you might find in some patients this is a normal hepatic vein and we have done the occlusion and you find these collaterals developing. These are this is a additional hepatic vein, accessory hepatic vein, and this can also be clinically represented that diagrammatically the accessory with the development of the accessory hepatic vein, the main wedge HVPG will be almost low or normal because the pressure is transmitting. So the presence of accessory hepatic veins, collaterals, they will decrease the HVPG, main hepatic wedge pressure, or indirectly or incorrectly measure the pressure. So in ACLF group of patients, this is a co-to consensus, and we see the patients who have higher pressure, they have higher chance of bleeding, high risk varices, and as the pressure decreases, the bleeding risk decreases. And the main contributor to this study was for the pressure was the only single randomized control trial available till now. So in this study, treatment with carvedilol improves the survival of patients with acute and chronic liver failure. 136 patients were enrolled, and having HVPG more than 12, the patient who received carvedilol has a better prognosis as compared to the patient who received placebo. Also, they developed less AKI and less SBP incidence. So measuring the hepatic hemodynamics is important, and thereby increasing, starting them on the beta blockers. But not always in cirrhosis also, the wedge hepatic pressure or HVPG will corroborate clinically. In NASH group of patients, the HVPG can be slightly low or slightly low rather than the patients who have hepatitis C or alcohol. In this study, you can see there's a static or more consolidated readings, but in this patient, in this slide, you can see some haywire going, the dots are going. So these NASH patients have larger confidence interval. So this study, which is published in J Hepatology, they showed that NASH group of patients, there was disagreement between wedge hepatic pressures and portal pressure in the NASH as compared to the other group of patients. They have taken control of the hepatitis C also and the alcohol also. So what are the prerequisites to measure HVPG? Recent food intake increases the portal vein flow, so raising its pressure. So fasting of 4 to 6 hours is recommended pre-intervention, not the fasting which we usually do in ward, that we make the fasting since 12 midnight. So they usually, the procedure in 4 and 5 p.m. they have 14 to 16 hours of fasting, which is not required. 4 to 6 hours is enough. Sedation is not required. Propofol and fentanyl are not advised. They change the portal pressure. So midazolam can be given. A simple liver ultrasound is important because it can detect the SOL, portal vein thrombosis, any obstructive cholestasis, or any abscesses, which becomes a relative contraindication to do transjugular biopsy. With ascites, the displacement of the liver can impede the catheterization of the hepatic vein because of the unfavorable angle between the hepatic vein and IVC. So paracentesis before doing the TJLB is important. Medical history in the form of anticoagulation is also important because the patient on anticoagulation should be asked to wait. I'll come to it later. So to prepare the patient, we have basic equipment like fluoroscopy machine, transducer, ultrasound device. Pressure, for pressure measurement, we have pressure transducer. Place the transducer at the level of right atrium. So it is important to change the level of the pressure. Prepare the patients, and the paper digital imaging, digital recording is also very important to save the HVPG recording. Ensure the patient is fastened and has consented to the procedure, low dose midas, and prepare sterile conditions. So if you see, this is our hospital patient. So we have first checked with the ultrasound, and this is an internal jugular vein, internal carotid artery. With the help of anesthetist, we were which usually cannulate the hepatic vein, and they introduce the introducer sheath in the right IGV neck, and the needle is there, and the right IGV is cannulated with the introducer sheath. So through this sheath, we will be able to perform the HVPG or TJLB in these patients. So the thick wire, stiff wire is cannulated towards the right hepatic vein, and we have performed the hepatogram. There is no leak, there is no accessory hepatic vein or any filling of the other collaterals, and the sheath has been introduced to this through this method. So hemodynamic measurement, venous access we have achieved. The following the IGV puncture, 9 French 35 centimeter vascular sheath has been introduced in the SVC RA junction, and 5 French MPA, that is multi-purpose angiographic catheter with the thermohydrophilic wire, was advanced to cannulate the hepatic vein. Position is confirmed with the contrast injection as I showed. The catheter is carefully withdrawn while maintaining the wire position exchange for a rigid cannula using continuous traction to prevent displacement. And the pressure measurement, RA IVC, measure pressures in the RA and IVC near the ostium of the hepatic vein. So it is important where to measure the hepatic vein pressure, where to measure the IVC, where to measure the RA. So free hepatic vein pressure measured 2 to 3 centimeter from the hepatic vein outlet for at least 30 seconds until the stability. Wedge, inflate balloon and measure pressure only with the complete occlusion of the hepatic vein for at least 60 seconds till the stability. We have to measure all in triplet and calculate hepatic vein HVPG, that is subtraction only. Slow recording speed of 7.5 millimeter per second should be set, and measured wedge and hepatic vein pressure should be measured. In case of significant inconsistency, that is more than 2 millimeter of changes between individual reading, technical sources of error like incorrect wedge position, catheter tip adjacent to the vessel wall, recalibration to 0. Whenever you find these technical difficulties, always ask the nurse to recalibrate it to 0. Transducer at mid axillary line should be excluded, and they should be important to be taken care of. So the recording is like this: the free and the wedge hepatic vein pressures. This is IVC and this is RA. So RA is usually slightly lesser than the free, and also the IVC is slightly lesser than the, unless there is some IVC block or any vascular block. So for the liver biopsy, cannula is approached to the IVC hepatic vein junction, and patient is instructed to inhale and hold their breath, enabling smooth advancement of the rigid cannula into the hepatic vein. After entry, the patient is allowed to exhale. Both the catheter and guide wire were removed, making the catheter in the C2 and the rigid cannula in the C2. So this is a biopsy gun, true cut biopsy needle. We have seen the hepatogram which was going like this, but we have to angulate the biopsy needle so that it should be taking the biopsy through the parenchyma, not subcapsular, which is usually in some cases we find that subcapsular biopsy is there, and this is a sample which has been taken with the true cut biopsy needle. So same. So in ILBS we perform this cap technique, which is a controlled wire, angled cannula and breath hold while performing the liver biopsy. Follow up these patients is important. Remove all the sheaths of the vascular system and apply pressure to the access site for 5 minutes. Instruct patient to remain in recumbent position for the duration of post-procedure monitoring. Administer additional pain relief or crystalloids for circulatory support as needed. Abdominal ultrasound or blood count check before discharge may be used to exclude post-procedure bleeding, and ultrasound should be indicated if the patient complains of right hypochondrium pain or any tachycardia. You should order VBG at least, so that the hemoglobin drop can be there, can be checked, or lactate level, other hemodynamic parameters which are deranged can be checked before discharging the patient. We usually keep these patients for at least 12 hours in the post procedure, so as to see the patient not developing any complications. Till now, in the last 1 year, there is only one complication. I'll come to it. In some special group of patient like contrast allergy, the patients some have, so we can pre-medicate them with the methylpred or the oral hydrocortisone also, and then we can successfully perform the hepatogram and cholangiogram. Patient on anticoagulation and antiplatelet therapy. So this slide is important. Anticoagulation should be stopped if possible. Direct oral anticoagulant should be omitted 2 days before the procedure. In case of warfarin, normalized INR should be achieved. Dual antiplatelet like clopidogrel, prasugrel, ticagrelor should be stopped 5 to 7 days. In dual antiplatelet therapy, it should be considered if the biopsies can be delayed or if clopidogrel or these can be stopped. Aspirin monotherapy can be continued. Anticoagulation and antiplatelet can be restarted the day after the procedure. So for these patients which have heart disease, NASH patient, cardiac patients, this anticoagulation and antiplatelet is important. If we see the IL-based data, the transjugular liver biopsy is, we performed this study in the last January 24 to December 24, and we have included 704 patients with a mean age of 46, 74% were male, and sample adequacy was seen in 93.7%, with a mean sample length was 1.41, and mean portal tract were 7. So most of the patients were alcohol and MASLD, and some were cryptogenic. Adequacy was 93.7%, size was 1.4, and mean HVPG was 15. Subcapsular biopsy was seen in 6.5% of patients. Coming to complications of biopsy, the VAS, there's a visual analog score of abdomen, was 2 for abdomen, and it was almost 2.5 in the neck. The patient usually complained of pain, for which the opioids were given in only 5% patients. Otherwise, hematoma was seen in 2 patients. One required the intervention, but one improved spontaneously. Hematoma neck was seen in 8 patients, which was for improved spontaneously, not requiring any intervention. If you see the timing of our procedure, pre-procedure usually in the daycare, patient stays in for the 20 minutes, and the IGV line requires almost 6 to 7 minutes. TJLB time is 6 to 7 minutes, and HVPG time is 6 minutes only. So we perform very fast, and in the West it is almost like 20 to 30 minutes for the TJLB and HVPG. And if we have characterized these patients according to the low MELD and high MELD to see the complications, but we found that in the low MELD or high MELD, the complications, there were no complications, and the sample length and the portal tract were almost similar. The number of portal tract was 7, and the length was also the similar. According to platelet count, because the platelet count is becoming a contraindications, and like a patient with coming with 20, 30. So we categorize these patients to less than 50, 50 to 100, and more than 100, and still we were not able to find any discrepancy or any length. So they were almost the same, and we were able to perform successfully in patients with platelet count of less than 50,000 also, with a portal tract of 6.9 and sample length of 1.39 centimeter. According to INR also, there was no bleeding risk, and portal tract and sample length were similar. Subcapsular biopsy were more in the CLD group rather than the ACLF group, because they have a they have small liver, so fragmentations are usually seen. Small liver, the angulation is also very difficult. With the ascites also, it becomes very difficult to go through the hepatic vein and take a adequate puncture. So if we have categorized these patients according to the biopsy size, portal tract with adequacy, and we see that as the sample adequacy was achieved, there were the more adequate samples have the higher portal tract, and there were size of the biopsy length was also high and increased, and the number of attempts were also very less. The same abstract has been selected for the APDW also for the travel grant of $1,500 US. So if we see the future research in this group of patients, right heart catheterization and cardiac indices to predict prognosis in ACLF there's no study I could find. Transjugular sampling to track molecular changes during the ACLF treatment, recovery or progression, there's no data. Understanding metabolomic differences between the hepatic, pulmonary and systemic circulation in ACLF also, there's no data. So with this, I conclude that HVPG stratifies short-term risk in ACLF and guides portal hypertension strategy. TJLB safely delivers the etiologic clarity and needs the and can be done in patients where the percutaneous biopsy unsafe. We can do both in the same setting, but we should have a more safer approach that bleeding or hematoma chances should be negligible. That's all. Thank you.